Hi, my name is Rachel Jensen, and I will be talking today about looking beyond the numbers, a comparison of operative self-efficacy, supervision, and case volume. To start, I just want to talk a little bit about self-efficacy theory. This was first described by Albert Bandura in the 1970s, and it's part of social cognitive learning theory. Self-efficacy is defined as the belief in one's ability to accomplish a task, and we know that self-efficacy is essential for personal growth. However, residents report operative self-efficacy deficits for 10 commonly performed general surgical procedures. Therefore, we sought to evaluate how operative independence and case volume contribute to perceptions of self-efficacy. Operative independence speaks more to the quality of the operative experience, while case volume speaks more to the quantity. To do this, we conducted a self-efficacy survey, which was distributed as an optional post-test section of the 2020 in-service exam. On this survey, residents were asked to rate their ability to perform 10 common general surgery operations without assistance. We considered self-efficacy to be a binary construct, where a score of 5 was considered self-efficacious and a score of 1 through 4 was considered not self-efficacious. We then compared this to operative independence data. We obtained this data from the simple OR database for the same 10 operations, and we looked specifically at the level of case supervision or operative independence granted. The simple OR app uses the Swish scale, where a score of 1 is show and tell, and a score of 4 is supervision only. We considered operative independence to be a binary construct, so only a score of 4 or supervision only was considered to be operatively independent, and a score of 1 through 3 was considered non-independent. Finally, we compared this to case volume information from the ACGME 2020 National Data Report. We looked at mean case numbers for those same 10 commonly performed operations. Unfortunately, there was not enough granularity to be able to identify 3 of the 10 operations, including diagnostic laparoscopy, wide local excision, and laparoscopic right hemicolectomy. You can see here in the results that we have organized these 10 commonly performed operations into 3 different self-efficacy tiers with 3 to 4 cases per tier. In the high self-efficacy tier, you can see that the percent of self-efficacious PGY-5s is about 88% compared to 68% in the mid self-efficacy group and 25% in the low self-efficacy group. When you move over to the next column and you look at the percentage of cases completed with operative independence, we see similar trends. So in the high self-efficacy group, about 33% of those cases were completed with operative independence compared to 14% in the mid self-efficacy group and 5% in the low self-efficacy group. When we look at mean number of cases, in the high self-efficacy group, we have a mean of 92 cases compared to 21 cases in the mid self-efficacy group and only 11 cases in the low self-efficacy group. We also looked at correlations. So specifically, we looked at the correlation between self-efficacy, supervision, and case volume. The correlation between self-efficacy and supervision was strong with a Pearson value of 0.85. There was no significant correlation between self-efficacy and case volume. However, there was a strong correlation between supervision and case volume with a Pearson value of 0.79. So in conclusion, we saw in this study that there's a strong correlation between supervision and self-efficacy, suggesting that opportunities for operative independence are critical to the development of self-efficacy. However, we saw no significant correlation between case volume and self-efficacy, but we did see a strong correlation between case volume and supervision granted. In competency-based medical education, case volume alone should not dictate the level of resident responsibility or operative independence that's granted. While case volume certainly contributes to a body of surgical experience, this alone does not equate to self-efficacy. So in the era of competency-based medical education, it is absolutely essential to look beyond case numbers in order to train self-efficacious graduates. In the future, we hope to target opportunities for operative independence and case volume in order to facilitate a positive self-efficacy cycle, as you can see in the image on the bottom right in the results section. We also hope to consider other contributors to perceptions of self-efficacy within the context of Albert Bandura's self-efficacy theory. Thank you so much.